Good afternoon, everyone, and welcome to VitroLife Group Academy. My name is Nasser Al-Asmar, and I am Scientific Director of the Igenomics Academy. And today, as the first session, ERA updates and Q&A, I have the pleasure to introduce you my colleague and friend, Tiffany Stankewicz, that is Product Director of Endometrio at Igenomics. She's going to make a short introduction regarding the ERA updates, and later on, we will go with the Q&A session. So, Tiffany, whenever you want.
Perfect. Thank you, Nasser, for the introduction. So, we're going to start with a quick introduction before we jump into questions and answer session. As disclosure, we're employees of Igenomics, part of the VitroLife Group. But let's start with the preconceptional space. We know that this is composed of several features, starting with the endometrial microbiome. That's the microbial community that the embryo encounters at implantation, followed by materno-embryonic crosstalk, so that communication between the implanting embryo and the endometrium, endometrial receptivity, and then finally decidualization that leads to placentation. But today, we're focusing on endometrial receptivity. I think we're all familiar with the window of implantation. It's a time when the endometrium is receptive to a blastocyst implanting. We've always assumed that it was constant in all women, but with our research, we now know that some women might have a displacement needing additional hours of progesterone exposure. We refer to this as being pre-receptive, whereas other women need less progesterone exposure prior to transfer, and we refer to these women as being post-receptive, where the window of implantation has already passed at the standard time of transfer. As far as scientific support for ERA, we have over 30 publications relating to the endometrial receptivity analysis test, with 16 external publications supporting the use and 6 internal. There we go. So there are some clinical considerations we need to keep in mind when reviewing publications, and I want to take this opportunity to review them now. So different studies have recently indicated that the analysis of endometrial receptivity does not provide a benefit. However, we have to understand the population being analyzed in those specific publications. The ERA test is indicated for patients with recurrent implantation failure, where the risk factors such as embryo factor are ruled out because it is the population in which there is a greater risk of presenting a clinically relevant displacement. And let me explain what a clinically relevant displacement means. So when we think of the phases of endometrial receptivity, we need not to think of them as being black and white boxes, but instead a gradient. So for instance, if a patient's transcriptomic profile is found to be in this location, so in the transition phase between a pre-receptive 1 profile and a receptive profile, we can see they're not very far from achieving a receptive endometrium. This means even if we add 24 hours more of progesterone exposure, as indicated by the pre-receptive 1-day result, it's not going to provide a significant benefit. And that is why we haven't seen in some populations, specifically good prognosis patients, and the clinical trials studying this population, a big difference between those patients undergoing ERA or those patients undergoing a standard embryo transfer. On the other hand, when we look at the transcriptomic profiles for patients with recurrent implantation failure, we see a more clinically distinct displacement. So you can see here for the RAF group, this is the area further from the receptive phase. So when we're adding an additional 24 hours more of progesterone exposure, we see a significant increase in clinical outcome, because it is unlikely if we transfer during the pre-receptive phase where the RAF group is falling, that the embryo will not properly synchronize with the receptive endometrium, leading to failed implantation. As far as the use of ERA in recurrent implantation failure, I'd like to review several points. As I mentioned before, recurrent implantation failure is the main indication for the ERA test. ERA has the highest published clinical rates for patients with RAF compared to any other endometrial receptivity tests in the market. Patients with RAF who underwent a personalized embryo transfer guided by ERA had significantly increased clinical outcomes versus those patients who did not undergo a personalized embryo transfer guided by ERA. RAF patients who undergo a personalized embryo transfer by ERA were found to have similar outcomes to those achieved by good prognosis patients. So what we're effectively doing in the RAF patient population is raising their clinical outcome rates to those expected from the good prognosis patients. And then lastly, numerous internal and external publications demonstrate the utility of the ERA test in recurrent implantation failure population, showing significantly improved clinical outcomes when patients undergo a personalized embryo transfer guided by ERA. In fact, I have included 12 different publications supporting the use of ERA in RAF. To give a quick overview of some of the results of this publication, I chose two recent publications, one from Jha et al. In 2022. Here, they compared the clinical outcomes between RAF patients who underwent a personalized embryo transfer guided by ERA versus RAF patients who underwent a typical frozen embryo transfer at the standard time. And what this group found was a significant improvement in implantation rate, pregnancy rate, and clinical pregnancy rate for those patients with recurrent implantation failure who underwent the ERA test and subsequent guided personalized embryo transfer. In another recent study by Rose in 2022, entitled Identifying Women with a Narrow Window of Embryo Implantation Using the Endometrial Receptivity Assay, he indicated that normally transfers would be performed at P+6 in all patients, in which he obtained a 59.1% pregnancy rate. However, he came across a subgroup of patients consisting of 24 that after several transfers at P+6 did not get pregnant. These 24 patients had at least 2 failed IVF cycles with a minimum of 3 good quality embryos transferred. In total, 94 embryos were transferred without implantation. Half of these patients, so half of the 24, had previous failed transfer with either donor oocytes and or known euploid embryos. Now, what he found was that 17 out of the 24 patients had a displaced window of implantation at their standard time of transfer on P+6. These 17 patients then underwent a personalized embryo transfer guided by their ERA results, in which 13 got pregnant and 11 had successful deliveries. So just taking at a quick look at implantation and live birth rates in this group of patients. So in their previous FET at the standard time of transfer, implantation rate and pregnancy rate were 3.4% and 1.1% respectively. And we see a significant increase when applying the personalized embryo transfer guided by ERA, with implantation rates achieved of 50% and a live birth rate of 64.7%. Now, moving on to the second clinical consideration that we have to keep in mind when reviewing publications is that monitoring of variables to confirm reproducibility of results. We have seen some publications in which there's been a lack of proper endogenous progesterone control. So this is anything other than less than 1 nanogram per mil within the 24 hours prior to the first intake of exogenous progesterone. So if we're not properly ensuring endogenous progesterone is less than 1 nanogram per mil within the specified time, we cannot ensure the reproducibility of the findings. And the obvious reason behind this is that we know that progesterone is the initiator of the plasma membrane transformation of the endometrium from non-receptive state to a receptive state. So if a patient has an earlier exposure than anticipated, then we could not reproduce that in a subsequent transfer cycle. So this is extremely important and imperative that you're measuring endogenous progesterone and that it's less than 1 nanogram per mil within the 24 hours prior to the first start of progesterone. The other issue is that there's no obvious control over reproducibility as far as number of hours or the protocol itself. So we need to always verify that the protocol is being replicated between the mock cycle and transfer cycle for every patient case. So if you applied an HRT in the mock cycle, you want to apply an HRT in the transfer cycle. But not only that, we need to also consider the progesterone protocol used. For instance, if we're using 400 milligrams of micronized vaginal progesterone twice a day in the mock cycle, we need to do the exact same thing in the transfer cycle to ensure reproducibility. In many published studies, this is something that hasn't been verified or controlled. Another point is number of hours. We need to ensure that we're transferring according to the personalized embryo transfer timing recommended. So for instance, if a patient's found to be receptive at 120 hours of progesterone exposure, the recommendation will say to transfer at 120 hours plus or minus 3 hours. Ensuring this will ensure a transfer at time of optimal receptivity. And then the last point I want to make here is relating to probability of pregnancy. The endometrial receptivity analysis, the goal here is to increase the probability of pregnancy. So if I show you an example here, let's say a patient's transcriptomic profile falls right within the middle of the pre-receptive 1-day phase. If she is given 24 hours more progesterone, then she will ensure transfer at time of optimal endometrial receptivity. Now, let's say instead of following the recommendation, she undergoes transfer during the pre-receptive 1-day phase. It is unlikely that implantation will occur since we're transferring outside of optimal receptivity and we're losing proper synchronization between the implanting embryo and a receptive endometrium. We try with transfer number 2, it happens again. Transfer number 3, again, failed implantation. And then perhaps by the 4th transfer, we get a pregnancy. And maybe this is because due to just a natural synchronization between the embryo. Perhaps, this is her 4th transfer. Most likely we transfer the best quality embryos first. So maybe this embryo was poor quality, perhaps an early blastocyst requiring further expansion, hatching, and undergoing the phases of implantation. We keep in mind that embryos don't readily implant upon immediate transfer to the endometrium. They float around for a bit. But in this case, again, due to the morphokinetics of that specific embryo, there could have been natural synchronization. But what did we lose in the meantime? We lost 3 additional embryos to transferring into a non-receptive endometrium. So we need to keep that in mind. So the key messages, just to wrap this introduction up, is 1, always keep in mind the population analyzed. ERA is indicated for patients with recurrent implantation failure. 2, is always to monitor variables that can affect reproducibility results. So again, properly controlling endogenous progesterone, ensuring replicating cycle to cycle for patients, and then always following the ERA recommendation, provided the timing that is given on the report. And then keep in mind the probability of pregnancy. A non-receptive patient has a lower chance of pregnancy. This does not mean a 0%. So as that example I showed, in that case, the patient finally conceived on embryo transfer number 4. So even if you're transferring to a non-receptive endometrium, you could potentially get pregnant, but what have you lost in the meantime? And then lastly, when reviewing publications, we need to keep in mind these above 3 points, but we also need to fully rationalize the data presented. On top of that, we need to weigh properly results from clinical trials that are performed in the correct manner versus opinion pieces that may be due to misunderstandings or faulty reanalyses. So I think that's a good review. We can start with Q&A.
Thank you. Thank you very much, Tiffany, for the nice introduction. I don't know if... Okay, so I was saying that thank you very much for the nice introduction. And there's any question in the audience? Because I do have some questions. Actually, they are coming from previous webinars. So I would like to ask you so you can explain. We are recording so people can see it. First question would be like, are there any intentions by iGenomics or other groups to have a prospective study to look at ERA in implantation failure patients?
Yeah, so we hear from many clinics who plan on doing their own research, and I always encourage looking at your own data, specifically in patients who've had previous implantation failure, to see how the test is being applied and the utility in your own clinic. So we always encourage the publication of that. We know some groups are working on looking at their data and maybe presenting it in either abstract or publishing. Now, as far as a prospective study, iGenomics this year is actually, we have our own sponsored study that we're launching late this summer, early fall. And this is going to be a non-selection study to understand the utility of ERA better in patients with implantation failure. So this will be multi-center, international. So we have clinics participating in Europe, United States, South America, Asia. So we're really going to have a diversity of patients and specifically looking at implantation failure.
Okay, so there's a lot of studies going on, right?
There's a lot of studies going on.
Okay, cool. Thank you. Also, we were wondering if you think that will ever be utility for ERA in good prognosis patients?
Yeah, so what we were saying before, so in the previous studies, we didn't see a significant benefit in patients with a good prognosis. So these are patients at the first IVF appointment. Now, one thing to keep in mind is that some of these patients could eventually become RAF patients. We just can't identify those from the beginning. However, there may be some special cases in which ERA can be applied to, say, quote unquote, good prognosis patients or patients that we expect to be good prognosis. Maybe this isn't a case where a patient's undergoing PGTM, for example, and they only have one chance at the embryo implanting. They want to make sure they kind of check the boxes and that they're transferring back into a receptive and even a healthy endometrium because they only have that one precious embryo. So we do see some case-by-case basis, and I think, you know, instead of having a blanket statement saying, yes, you can apply to everyone, clinical judgment is really important. But in my opinion, I think as far as good prognosis patients, the endometrium is obviously very important. It's the other half of the player when it comes to implantation. So maybe these patients would more likely benefit from endometrial testing with microbiome, so like Emma or Alice, ensuring a healthy endometrium, especially if we have a healthy embryo. So we'll see with that.
Okay, perfect. Thank you. Thank you very much. And also, lastly, we do have like some negative publications or that they don't show any benefit regarding ERA. So can you address a little bit or can you explain a little bit about it?
So I think this is too a misconception. We actually don't have a lot of quote unquote negative publications against ERA. There's, you know, saying that there's no benefit. So for example, there's a recent randomized clinical trial by the Shady Grove Fertility Group in the United States. So this was published by Doyle and her team, in which they were studying specifically the good prognosis patient population. They want to understand, okay, is there a wider indication to ERA? And what they found was that there was no clinical benefit of applying ERA in this population. So we actually published the same results in our RCT in 2020, in which we didn't see a significant benefit in live birth until the cumulative rates were studied. So this is something that actually the Shady Group Fertility Group is looking at now. So it'll be really interesting to see if their results keep matching ours. But we don't consider it to be a negative publication. We've actually improved our tests following the results of this. And we see, okay, you know, at this time, ERA may not be as useful for the good prognosis patients, but we know that there's support for patients with recurrent implantation failure. Now, with that said, there definitely are some negative pieces out there. So this is where I was saying we need to apply properly and weigh properly good clinical trials versus opinion pieces, because many of these negative come from opinion pieces that are not peer-reviewed clinical trials. So it's important to keep that in mind. But some of these are based upon misunderstandings that are leading to faulty reanalysis. But the danger here is the misinformation that's getting transmitted to patients. So patients who could really benefit from undergoing receptivity testing, again, the RAF group.
Cool. Thank you very much. And there's any question on the audience? Well, I guess the last one for me is that as far as we are at ESHRE, we cannot live without comment the guidelines for recurrent implantation failure. So do you have anything to say about these guidelines?
Yeah, so this was the recent publications of ESHRE guidelines for patients with recurrent implantation failure, redefining what this means, or kind of defining more what RAF means, since we haven't had an official definition, and then the interventions and treatments that should be applied. So we know that recurrent implantation failure is a real problem. There's no denying that. I don't think we can tell a patient who's had 3 or 4 failures that they're not actually, experiencing something, because they are. But I think it's important to remember that it's even stated within the guidelines. These guidelines should not be interpreted as setting a standard of care and should not replace the need for application of clinical judgment to each individual. I think that's very important to keep in mind. It's not saying don't do this or don't do this. It's just supposed to guide you in your own clinical experience and your own clinical judgment when you're meeting with patients. So as a review of what was said, so regarding the ERA test, this is something that can be considered. And what I found was what was interesting when reviewing this publication is that, for example, ERA can be linked to other recommended investigations, such as reassessment of lifestyle factors. So this is something given a green light by the ESHRE guidelines. Specifically, if we're looking at BMI, because we know that there is a relationship between BMI and increased displacement of window of implantation. So some of these recommendations go hand in hand. Chronic endometritis detection is another test that can be considered according to the ESHRE guidelines. So for example, with our Alice and Emma tests, we look specifically at pathogens related to chronic endometritis. It's stated in the guidelines that chronic endometritis screening already seems to be routinely investigated, with 85% of clinicians indicating that they're already doing this in their practice. And we know that there's been reports of significantly improved live birth rate and ongoing pregnancy rate in patients who have chronic endometritis but are cured following antimicrobial therapy, as far as antibiotics and I guess probiotics in some cases. However, what they mentioned is that this particular testing is hampered by different or a lack of standardization. So we know that there's differences between different methods of chronic endometritis testing. So for example, our platform is a molecular platform where we can actually identify the bacterial pathogens present. So we can focus on giving a specific and targeted antibiotic treatment. So we're not using broad spectrum antibiotics, which keeps the patient at risk for a recurrent infection. So that's important to keep in mind. And then lastly, they talk about microbiome testing in general. Now, this is where it maybe is a little bit foggy. It'll say not recommended, but we need to keep in mind it's not recommended for routine use. The reason being that further research is necessary. And this sort of makes sense because until recent years, I would say until the last 5 or 6 years, we lived under this assumption that a healthy endometrium was sterile. And we didn't really understand the endometrial microbiome. So this is still an emerging concept. The microbiome in general is emerging. Mm-hmm. We're only about 14, 15 years into the Human Microbiome Project. So I think that we're going to see more research coming out. In fact, there have been recent publications that came out after the preparation of this that weren't included in the analysis. One specific from the, Dr. Iwami's group in Japan, which showed a benefit specifically for recurrent implantation failure patients who underwent molecular testing, in this case with EMA, and then was treated accordingly to the results. So they had significant improvement in clinical outcomes versus patients who did not undergo microbial testing from the endometrial microbiome. So I think as more evidence comes out, the view is going to change on microbiome testing in general. And as I said, I think we're talking about RAF patients here. I think that it could be extended outside of that because we know that none of us are immune to microbial shifts anywhere in our body from time to time, especially with so many external factors such as antibiotic use, sexual intercourse, hygiene. This can all affect the microbiome. So ensuring, is the endometrial microbiome healthy for this healthy embryo? I think it's going to be a big factor in the future.
Yeah, absolutely. Yeah, absolutely right. So if there's no more questions, I think that after listening to you, Tiffany, we can summarize and say that ERA works, but we need to take into account, first thing, patient population. So we need to looking for the specific patient or indication in order that they get benefit from the ERA. Second one, we have to follow the instructions. So I cannot say this tool is not working if I'm not following the recommendations. So we need to be strict and follow the recommendations of the ERA report. And third, that a patient that is non-receptive has zero chances to get pregnant, but has lower chances to get pregnant if you don't use the ERA in order to follow their recommendation.
Correct.
Okay.
Yeah,
anything else from your side?
No, I think that's it. I think it was pretty comprehensive
So
talk.
Thank you very much, Tiffany, for this talk, and see you soon in the next session. Bye-bye.